Hello, and a very warm welcome to everyone joining us for today's Select Science webinar titled Understanding the Complexity of Urinary Tract Infections and the Role of Urinalysis in Early Detection. My name is Ellie Abbott, and I will be moderating today's webinar. I'm delighted to be joined by Dr. Jeffrey Henderson, Associate Professor of Medicine at Washington University, and Lisa Rittenauer, who is the Director of Health Services at the University of Akron. Please feel free to submit any questions you may have using the speech bubble icon to the left of your screen at any time during the webinar. And don't forget that you are entitled to PACE and/or accent credits upon completion of the webinar and your evaluation of the session. So, without further delay, I would like to hand over to our speakers for today's presentation.
Thank you so much, Ellie. In this session, I'd like to discuss the presentation of urinary tract infections from the point of view of a physician. First, an overview of urinary tract infections, or UTIs. This is among the most common type of infection encountered by physicians in both the outpatient and inpatient setting. In fact, the majority of US women will have experienced at least one urinary tract infection in their lifetime, as you can see in the figure on the right. Urinary tract infections actually encompass a broad array of infection subtypes, and they can present in a remarkably wide array of ways, from self-limited bladder infection, which is familiar to many, all the way to sepsis, where the infection spreads from the urinary tract to the bloodstream. Many patients with urinary tract infections, a notable subgroup of patients with urinary tract infections, rather, will relapse, will have frequent recurrences of UTIs, and this subpopulation is familiar to many treating patients in the outpatient space. It's also notable that urinary tract infections motivate substantial antibiotic use at a population level. Although a lot of our discussion focuses on urinary tract infections in women, which are the most commonly encountered circumstance for UTIs, it's notable that men also get urinary tract infections. They tend to do so later in life when prostate issues increase risk for UTIs. And we can see that in this graph of the prevalence of bacteria detected in the urine of just people, normal volunteers off the street, so to speak, that men increase, that frequency increases in men later in life after about age 50. First, a review of urinary tract terminology. Of course, this is an infection type that has given rise to many terms that are frequently used in the clinic, and I'd like to cover some of those here. Foremost among these, uncomplicated versus complicated UTI, which sounds like an unusual designation, but when people are talking about uncomplicated urinary tract infections, they're generally referring to a urinary tract infection in a reproductive age woman, which is a fairly stereotypical and commonly encountered type of UTI. Complicated UTIs are just about everything else. People with instrumented urinary tracts or surgically altered urinary tracts. Any man with a UTI is regarded as complicated, or something like the presence of diabetes makes a UTI complicated. The next term you'll hear quite frequently is cystitis. This is another way to say bladder infection. The symptoms of cystitis are urinary frequency, so frequent urination, a sense of urinary urgency, sudden need to urinate, and pain in the lower abdomen area. Pyelonephritis is another way to say kidney infection. Kidney infection has many of the features of cystitis, but often has flank pain. So in the lower back off to the side, the patient will often sense pain. It often comes along with fever as well. Bacteriuria is the presence of bacteria in the urine. Pyuria is the presence of white blood cells or overt signs of inflammation in the urine. And then there's a term some may have heard that's really not regarded as a medically acceptable term per se, but it's urosepsis. This refers sometimes to patients, generally older patients, that have a change in mental status and have laboratory signs of urinary tract infection. But it is not really a formal diagnosis. So what is a urinary tract infection? I have described it in general terms, but here we should remember that a urinary tract infection consists of patient symptoms and pathogenic bacteria in the urinary tract, and that these two things together make up the clinical definition of a urinary tract infection. So we don't typically rely on laboratory identification alone, although if a patient is unable to report symptoms, that certainly informs our diagnosis. So foremost, what if we don't treat uncomplicated cystitis? So we're diagnosing things in order to treat or manage them. Why do we do this? Well, about a quarter to half of patients will actually resolve their infection with placebo only. So basically, people can resolve their infection without antibiotics. But we give antibiotics because if we don't, the symptoms are prolonged, the patient suffers. There is also a fairly small, but certainly non-zero chance that an untreated, uncomplicated cystitis case will progress to infection of the kidneys. That's certainly a progression of the infection we wish to avoid. And it's known from studies that if you give antibiotics, there's nearly a 5-fold increase in cure of your patient as compared to if you do not. And if we're using laboratory cultures of urine, there's a 10-fold increase in antibiotics getting rid of bacteria from the urine. So where can we find the bacteria that cause urinary tract infections? Well, in fact, most of us have the potential for urinary tract infection. We have bacteria that are typically associated with urinary tract infection colonizing our intestines. Some will have transient colonization of the vaginal mucosa. There is a subpopulation that at any given moment may have bacteria in the urine but don't have signs or symptoms of the UTI. There are those with cystitis and certainly pyelonephritis, and then there's a smaller proportion of the population that will actually have bacteria in the bloodstream and generally have come to medical attention by that point. So how do urinary tract infections happen? There is a classic so-called ascending route that is associated with over 95% of cases of uncomplicated cystitis. And this involves ascension, so to speak, of bacteria from the intestine through first vaginal colonization, then ascent of the urethra, next a superficial infection of the bladder surface. Many cystitis cases will stop at that point. Some will ascend further up the ureters, reaching the kidney, and at that point it's a kidney infection, and some of these bacteria will invade the parenchyma or the tissue of the kidney. Once that happens, it's a fairly low barrier to invading the bloodstream at that point. So that is the ascending route of UTIs. There's also something referred to as the descending route, and this is basically seeding of the kidneys from the bloodstream and bacteria appearing in the urine from that source. That's certainly a minority of cases. So why doesn't everybody get urinary tract infections if they're so common? Well, our bodies have a number of ways to resist or prevent these from happening. Among these is the colonization resistance in women of the urogenital flora. There are other bacteria, beneficial bacteria, that colonize the vaginal mucosa and make it more difficult for things like E. coli or the bacteria that cause UTIs to colonize. There's certainly mechanical effects of urinary flow. Just sweeping the urethra clean, making it difficult for bacteria to ascend to the bladder. Urine itself has some antibacterial and anti-adherence properties that make it more difficult for bacteria to adhere to bladder tissue. When bacteria does reach the bladder and sticks to tissue there, the cells that coat the surface of the bladder are able to exfoliate or basically release from the surface of the bladder and get swept out during urination. There's certainly an inflammatory response. Your immune system can arrive at the scene and eliminate bacteria in a more active way. And your body has ways to sequester critical nutrients for bacteria like iron, and these mechanisms get turned on upon the introduction of bacteria. So uncomplicated cystitis is well studied, as you might imagine, given that there are so many cases, and there are a number of clinical guidelines available, and they're quite detailed in how UTI can be diagnosed and treated. The guidelines from the Infectious Diseases Society of America are indicated here and are updated on a regular basis. So I've been speaking about uncomplicated UTI. So here's an example of a complicated UTI. So this is catheter-associated UTI. So when a patient has a urinary catheter in, this is regarded as a separate subset of UTIs. The symptoms are similar to what one would encounter with an uncomplicated UTI, but many people have catheters because of neurologic issues, and so for that reason may not be able to provide typical symptoms to the physician. Those symptoms may manifest instead as increased spasticity, autonomic dysreflexia in paraplegic patients. Many people are tempted to diagnose UTIs in these patients because the urine itself is cloudy or in some way malodorous. It's important to note this is really not a criterion for diagnosing UTI. It gets tricky with catheter-associated UTI. The presence of white blood cells or pyuria in the urine is not always helpful. As you imagine, the catheter itself can irritate the bladder and incite an inflammatory response. So while we often look for pyuria, it's not an absolute indicator that there's an infection. And culture is tricky. There's a differing threshold for what's considered a clinically significant amount of urinary pathogen. And sometimes that can simply be colonization of the plastic only at a point outside of the body. So this is a tricky, difficult condition sometimes to diagnose. Pyelonephritis, kidney infection, is an important subset, as I've already indicated, of urinary tract infections, partly it has a potential to damage kidneys, which are, of course, very important organs, and also have the potential to serve as a portal of entry of bacteria to the bloodstream. So we're very attentive to diagnosing kidney infections. And again, those symptoms that come with this may be lower back or flank pain and tenderness, as well as fever and chills. And those fever chill symptoms can sometimes indicate the bacteria some are already in the bloodstream. When pyelonephritis is part of the diagnosis, that is a case in which we always obtain cultures because we like additional information about the bacteria. The bacteria we're looking for and that are UTI associated are, in cases of uncomplicated UTI, are overwhelmingly E. coli, so a familiar kind of bacteria to many. That's at least 80% of uncomplicated cases of UTI. The remainder are cousins of E. coli, things like Klebsiella, for example, may make up other recognized uropathogens. Also, Staph saprophyticus. So this is Staphylococcus saprophyticus, different from Staphylococcus aureus, but it's a species of staph that is associated with urinary tract infections. When we look at, when we encounter hospitalized patients or patients who've had extensive contacts with the medical system, may have had a lot of antibiotic exposure, we see a much wider variety of bacteria. E. coli are still prominent among them, but we see more Klebsiella and other bacteria. Sometimes Pseudomonas shows up. Bacteria that are associated with much more extensive antibiotic resistance. So how do these bacteria do it? They part of what these bacteria in the urine have that allows them to cause UTI are what we call virulence factors, or special functions in the bacteria that help them invade and colonize tissue. Among these special characteristics are oxygen tolerance. So a lot of these bacteria, of course, live in the intestine where oxygen can be quite low, but they have ability to switch their metabolism to tolerate oxygen and thrive in higher oxygen tension environments like tissue. Some of these bacteria release an enzyme called urease. This is released outside of the bacteria, and as the name would indicate, it breaks apart urea, which is a compound that's abundant in urine. In so doing, that urease can raise the pH of urine, make it more basic, and also allow these bacteria to cause stones, which they can the bacteria can colonize. The hairs on this representation of bacterium in the lower right represent bacterial adhesins. So these are appendages of the bacteria that can stick to tissue receptors. They can stick to human cells and allows the bacteria to invade and move through tissue barriers. Bacteria can also make metal binding molecules to steal iron away from the host, for example. And a number of them make a capsule that make them difficult for white blood cells to recognize and kill. So after discussing how bacteria in the urine is an important part of UTIs, it may be notable that most UTIs really are not diagnosed by urinary culture. So why is this? Given that so many of the diagnoses are made in the outpatient setting, many are made with the idea of treating with antibiotics early, we're very sensitive to delays in receiving results back. And so that's one reason it takes a while for a culture to be completed and to give results back to the physician. There's also some issues of getting false positives. So the presence of bacteria alone without symptoms is not itself an infection unless there's a whole clinical context to it. We call that asymptomatic bacteriuria if there are no symptoms. And that's in fact not a condition that we wish to treat with antibiotics. It's one we prefer to leave alone. Giving antibiotics to somebody without symptoms or an infection is more likely to cause harm than good. So here is a picture of an experimental animal model of urinary tract infection. This is looking down using scanning electron microscopy at the surface of an infected bladder. And so what we see here in yellow is a leukocyte. So this is a white blood cell or a neutrophil, if you will. This is part of the immune response to E. coli, which you see in purple. That's these slender threads here. And all of this is playing out on the bladder surface, which is this brown background. And you can see ruffles in the surface of the bladder here. So this is, you might imagine, this is what a case of cystitis might look like if we could get into the bladder and look for ourselves. So how can we identify what's in the bladder? So one way to do this is to use the fact that all of these elements of cystitis can leave behind chemical fingerprints that we can use in a laboratory test. So the presence of white blood cells we can identify through an enzyme called leukocyte esterase, which is an enzyme released by these white blood cells. And when E. coli are present, they also release a characteristic compound into the urine itself. These E. coli, while they can breathe oxygen like you and I, they are also capable of substituting oxygen for nitrate. And when they do this, they produce an ion called nitrite. And that can be detected in the urine as an indicator that E. coli are present. And of course, any infected surface is irritated, it's inflamed. And with that, we often have leakage of blood into the urine itself. So that can be detectable through hemoglobin. How do we typically use all of these fingerprints? Well, they're wrapped up in a urine dip or a urine dipstick test that and that's depicted in the lower right. So this can be this test strip can be dipped into the urine. and developed, and you can monitor through color changes the presence or absence of these different components. So the leukocyte esterase is when positive, it's a test really specific for pyuria, or the presence of an immune response in the bladder. That's certainly consistent with UTI. A negative test, notably, doesn't absolutely exclude a UTI, but a positive test can certainly tilt you that direction. Nitrite, as I mentioned, a product of E. coli metabolism most commonly, but other bacteria can do this as well. It's not the most sensitive test, but when it shows up, it's relatively specific for an E. coli urinary tract infection. Hemoglobin as well is certainly seen with UTI. Its presence can really indicate that a UTI may be there, but you can again see UTIs without hemoglobin, so it's not an absolute either. And then lastly, there's usually a pH component to these dipstick tests. This is usually most relevant for UTIs when you're concerned about stones and infection stones because of that urease some of these bacteria make. You can see very high pH urine in that case. So a number of studies have been done on how well these tests tend to perform. You can use, again, the leukocyte esterase and nitrite together, and they have a relatively good sensitivity for UTI and specificity as well. Also encountered as an option for urine microscopy. So this is conducted, you get a clean catch urine specimen. By clean catch, I mean the patient urinates, pauses urination, and then resumes urination into a vessel for collection and laboratory analysis. Again, like a urinary culture, this has to be sent to a lab for microscopy, which introduces a delay. With microscopy, you can detect white blood cells. You can see these in the microscope. Sometimes you can see bacteria as well. Sometimes you can detect crystals in the urine. Of note, the presence of squamous cells, kind of large skin cells, is usually indicative of a contaminated specimen and is sometimes used to reject the specimen outright, that it's been contaminated with skin bacteria, skin cells, etc. And again, the limitations of this kind of test are the delays in getting the results back. And lastly, the other diagnostic test of use here is urine cultures. Again, you would get a clean catch urine specimen with this. These are typically reported as positive only if the number of bacteria in the specimen exceeds a certain threshold in a laboratory. And the laboratory will report back to you the species of bacteria that are present, and in many cases, their antibiotic susceptibilities. That report really focuses on kind of classic or typical urinary pathogens like E. coli. If E. coli is there above a certain count, you'll get a report that it's there and its susceptibility to different antibiotics. Of course, limitations here are delays in getting the results back. Again, false positive if the patient has asymptomatic bacteriuria, and there can also be contaminated samples. Sometimes you get non-uropathogens in the specimen. Sometimes if there's concern about contamination, it raises questions about whether that urine culture truly reflects bacteria that are in the urine or not. So when do we get a culture? In short, if a patient has a complicated UTI, anything outside the norm for a UTI is generally regarded as a reason to get a culture. You might not delay treatment for the culture, but you might want this information running in the background. If the patient has a history of an MDR or multi-drug resistant organism, if they in the past have had an infection with a bacteria that's resistant to many of our typical antibiotics, we'd like to know that earlier, right? So if the patient comes back with persistent symptoms, we know what to treat them with. And as I mentioned before, in a case of pyelonephritis, we always get a culture because we're risk averse. And we want to make sure if the patient continues to get sick, it's not because we've prescribed an antibiotic to which they're resistant. How to treat? Well, this has changed over the years. Guidelines around 2000 had trimethoprim sulfa. as a frontline antibiotic is the #1 recommended. And then the second line was a class of antibiotics called fluoroquinolones, such as ciprofloxacin or levofloxacin. And third in line was an antibiotic called nitrofurantoin. And then 4 is things related to penicillins or beta-lactams. Jump ahead to 2010, the guidelines moved to place nitrofurantoin as a #1 agent, trimethoprim sulfamethoxazole as the second agent, and a third agent called fosfomycin. So nitrofurantoin and fosfomycin are agents you'll almost exclusively encounter in the context of UTI. It's because these antibiotics are active against typical uropathogens, and the antibiotic itself reaches the urinary tract really well. It might not treat a tissue infection, but it can get into the urinary tract really well. And it can, and E. coli and its related bacteria tend not to be resistant to nitrofurantoin and fosfomycin. So for that reason, they're higher on the list of guidelines now. So why have these recommendations changed? Well, since the turn of the century, we've seen a large jump in resistance among urinary pathogens. And so that made our typical antibiotic recommendations less reliable. We see more antibiotic failures as a result. So a lot of these recommendations are really trying to keep up with that. Also, we're seeking to protect certain classes of antibiotics. So ciprofloxacin, the bacteria getting more resistant to it. It's also a useful antibiotic for other conditions. And there's a reluctance to drive resistance in a large population by giving out a lot of ciprofloxacin. So this part of this is antibiotic stewardship. There's also an increasing sensitivity to minimizing what we call collateral damage to the microbiome. So we have a lot of intestinal bacteria, of which I'm sure many have heard about. And in many cases, those do good things. They do favorable things for the patient. So we'd like to prescribe antibiotics that leave the good bacteria in a patient relatively intact, and direct our treatment just to the urinary tract itself. And so these are reasons antibiotic recommendations have changed and likely will continue to change into the future.
Thank you. And as Ellie said, I'm Lisa Rittenauer, Director of Health Services for the University of Akron, and I'm also a nurse practitioner. I'm pleased to be with you today to discuss point-of-care testing in the outpatient setting. Our health services clinic is a busy clinic, especially now that we are back into the new academic year and it's in full swing. We do a fair amount of point-of-care testing here, and today we're going to focus specifically on how and why we use point-of-care testing to better serve our patients. We offer point-of-care testing because it helps us speed our clinical decision-making, and that's important here so that we can get answers and treatment pathways underway in order to minimize disruptions for our students' lives. It's also that we make every effort to improve productivity for our staff, but more importantly for our patients. And then also on-site testing is extremely valuable for our patients who may have misdiagnosed themselves as having an STI, when in fact they could have an STI. And an example that we see frequently here in the clinic is that we will have a male patient that comes in with complaints of penile discharge and burning with urination and is wrongly assuming that they have a UTI. So with point-of-care urinalysis testing on site, we can quickly triage those symptoms, share test results with the patient, and begin a treatment plan. This frequently also becomes a teaching moment with the patient regarding sexual health and their general wellness self-care. Without urinalysis on site, the test would need to be sent out to a reference lab with a 1 to 2 day delay in turnaround time and potentially delaying treatment and exposing partners to an undiagnosed STI. So from a population health management perspective, on-site urinalysis testing is critical here in health services. So with that introduction, welcome to my office here at the University of Akron. We are a large and ever-growing public research university here in the heart of downtown Akron, Ohio. If you're a sports fan, you may be aware of the hashtag Just a Kid from Akron from our own LeBron James. If you're not a sports fan, you may know Akron as the home of everything from the Goodyear blimp to Firestone, Goodrich, and Goodyear tire companies. And while tires are no longer manufactured here in the area, the scientific research and development divisions are still alive and well here. So we have a long history of engineering and polymer science research here at the university, as well as hundreds of other degree options for our 16,000 plus students on our 3 campuses. We are also very proud to have students that represent 46 states and 44 countries from around the globe here on our campuses. So let me tell you a little more about health services specifically. Health services is located in campus and is one of the few nurse-led and nurse-managed clinics in the state of Ohio. We are staffed with nurse practitioners, RNs, and an LPN. And together we manage to see about 5,000 patients each year. We're open year-round, Monday through Friday, 8 to 5 p.m. After hours, we refer our patients to community resources for their urgent needs. We are fortunate to have 3 local hospitals, several urgent cares, and multiple retail clinics all adjacent to our campus. In addition to our students, we also see faculty and staff, and we're the initial entryway into the healthcare system for our international students. Our student population and our patient population here range in age from 17 to 80 years of age. So let's look at the testing we have to offer here at the university. For our reference lab work, we have an agreement with Quest Diagnostics that is a client pricing based system. On site, we do provide point of care testing for COVID-19, influenza, mono, pregnancy, strep, and urinalysis. You might ask, why on-site urinalysis testing? Our clinicians use on-site urine testing to triage our patients with complaints that can include burning, urgency, frequency, pain with urination, fever, hematuria, foul-smelling urine, and or a sensation of incomplete bladder emptying. With a single urine strip, we're able to also detect early warning signs for chronic disease such as diabetes and chronic kidney disease. In people of all ages, those diseases can be silent or asymptomatic. And early detection is key to clinical management and preserving the quality of life for those patients. Anecdotally, I can tell you that just this summer, we picked up 2 cases of undiagnosed diabetes on urine dipstick, and were able to get those patients established and managed in a primary care system. For UTIs, having leukocytosis and nitrites on the same strip also increases our confidence in ruling UTI in or out. Once diagnosis is made on the basis of presenting symptoms, the history, physical exam, and the test results, we can immediately start treatment without waiting for test results or trying to contact and bring patients back for additional appointments and treatment. And by the way, we do have on-site medications for our most common diagnoses that we see on campus. So that prevents our faculty, staff, and our students from having to travel to a pharmacy to get their medications. So they're able to get started sooner. Lastly, let's talk about instrumentation versus visual reading of urine dipsticks. Obviously, urine strips can be read visually. So why do we use an analyzer? Well, from my perspective, there's nothing more gross than picking up a bottle of strips and finding that it's wet after it's been used to match colors from a visual read. All I can do is imagine how many specimen strips have touched that bottle, and that is not a pleasant thought, with gloves or not. So in addition to that gross factor, anyone who has tried to read, time, and record results for 10 tests in 2 minutes knows exactly how hard it is to be accurate. The other thing we need to think about is everyone sees color a little differently. So using an analyzer gives us consistency in interpretation. We also find that analyzers are easy to use, and we're able to train new operators in less than 30 minutes, and we can get our test results in about a minute. So honestly, I can't imagine not having point of care urinalysis and an analyzer system on site for our particular population. On-site point of care urine testing helps us with our mission to expedite diagnosis and initiating treatment. And that is invaluable to our patient population. We want to return them as quickly as possible to pursuing their educational goals. And we can't wait to see what our students will go on to invent and create in their chosen careers and their aspirations. And with that, I do thank you, and I'm happy to answer any questions that you may have.
Thank you both for your interesting presentations. It's now time to move on to the Q&A part of this session. And to kick us off today, the first question we have here is for Dr. Henderson, and that is, could you please comment on polymicrobial urine cultures?
Yes, thank you for that question. When we think of UTIs, we typically think of a single species of bacteria. So polymicrobial urine cultures, I'm presuming, refers to the presence of multiple bacterial species in the specimen. Our attention, when we do get a polymicrobial culture result, it can result from contamination of the specimen. That's often our primary concern, that there are bacteria that have colonized the skin surface, that have inoculated the specimen itself and don't represent bacteria that are in the bladder or bacteria that are actually causing the infectious symptoms. So we often key into bacteria like E. coli when we get many species back. And treating that, generally speaking, is effective. I'll give you an exception to that, which is when there is a catheter present, which is usually in hospitalized patients or patients with other medical conditions. A catheter can be colonized by multiple species of bacteria, and I would regard the presence of many species there to be a subject of active debate in the field, whether it's necessary to use an antibiotic that covers more than one of those species that's present. But generally, we focus in on the classic, if you will, urinary species when we get this polymicrobial culture.
That's great, thank you. And the next question we've got here is for Lisa, and that is, how do you deal with discordances between urinalysis test results and clinical I'll read that one again. The next question we have here is for Lisa, and that is, how do you deal with discordances between urinalysis test results and clinical presentation?
Well, as you heard in Dr. Henderson's presentation, urine dipstick is a tool, and that there are oftentimes issues related to specificity in a test. So we look at the clinical situation, discuss test findings and what's going on with the patient, and then make the decision, are there compelling reasons why, despite what we see in the test strip, should we go ahead and treat the patient? Ultimately, it is the care and the best interest of the patient that we are looking for. So that's how we would do that.
That's great, thank you very much. And then we have another question for Dr. Henderson, and that is, what are your views on some of the home remedy approaches to preventing UTIs, like vitamin C and cranberry juice, or more recently, D-mannose?
Well, thank you for that question. That is a common question in the field of UTI, and it's sometimes a little frustrating because we can't point to an abundance of study results that point us clearly in one way or the other. The appeal of these home remedy approaches, of course, is that they're low risk, right? Cranberry juice, vitamin C, unless somebody's taking ridiculous amounts of these things, aren't going to do any harm. They're low cost, et cetera. But yeah, the data for them is fairly mixed. There have been a number of studies on cranberry juice or cranberry supplementation. First thing to remember is a lot of cranberry cocktails contain very little cranberry itself. When people do studies like this, the results have been pretty mixed. Many will say that it has no benefit. What I usually tell patients, I don't necessarily recommend they start using something like cranberry juice, but if in their experience it's been effective, I don't dissuade them. always possible that there are these idiosyncratic interactions between a dietary supplement and the patient that help them. And so I don't dissuade people from it, but I think the data is fairly mixed on the likelihood of that helping somebody out. For vitamin C, that's an interesting one. That's been lore for some time. And I think the idea behind vitamin C supplementation is the idea that you could acidify the urine with ascorbic acid, which is vitamin C. If you really look closely at the data for that, in fact, vitamin C supplementation generally does not acidify the urine at all. So the original assumption appears not to be true. And I've been unable to find indications that vitamin C does much of anything at all for preventing UTIs. And then lastly, the D-mannose part is kind of interesting. So that it has a nice theory to it. Those little hair-like appendages we see on E. coli surface, these adhesins, bind to carbohydrates or sugar structures on the surfaces of cells. And that can include a mannose that's hooked to the cell surface. So the idea is if you kind of flood the zone, so to speak, with mannose, you could make the bacteria stick to the mannose instead of the cells in the bladder and prevent UTIs. There's a little evidence that this might work, but it's not particularly strong. So that's kind of one of those stay tuned kind of things. Not high confidence in it, but again, it's low to no toxicity whatsoever and relatively inexpensive, perhaps. So it's one of those things that perhaps might work, but I think we have more to learn.
Perfect, thank you. And we have another question here for Lisa, and that is, have you noticed an increase in self-diagnosis in your years at the University Health Centre?
I have. As a short answer, yes. Dr. Google and WebMD have most certainly increased our self-diagnosis with our patients. But that also becomes a teaching moment with patients in talking about differential diagnoses and why what they think they have may or not be something that we would consider. But yes, there most definitely is an increase in people having preconceived ideas about what is going on when they present to us.
Great, thank you. And the next question we have here is for Dr. Henderson, and that is, what is the difference between acute cystitis and UTIs?
Great, I can give a fairly succinct answer to this one. This is a good question. So urinary tract infection is a very broad general term that encompasses many flavors, if you will, of infection. So acute cystitis is under that umbrella of urinary tract infection. Acute cystitis would be a sudden infection of the bladder. But a UTI could include not only bladder infection, but kidney infection. So acute cystitis is a more specific term.
Great, thank you very much. And we have time for a couple more questions. And this question is for Lisa, and that is, how long after taking antibiotics should a patient wait to take antibiotics for a recurring or episodic UTI?
That's a good question. So we know that when we prescribe antibiotics, that it will probably take 2 to 3 days for a patient to get symptom relief, but we do want them to continue the entire dose until it is all gone. If there is reoccurrence after that point, then there's some question as to, do we need to send a urine culture? Perhaps our antibiotic did not cover the specific bacteria that the patient is dealing with. Are there other risk factors that have occurred that may be of interest in whether we should treat again, or is this a situation that an individual may need to see a urologist for a more complex issue? Dr. Henderson, do you have any other comments?
Yeah, that's not as standard. If you're looking at guidelines, you're not going to find a very standard spelled out approach. And I think Lisa gave a really good answer to that. It becomes much more context specific and specific to the patient. And yes, we're seeking more information. Is it an antibiotic failure? Is it some other entity?
Great, thank you very much. And that brings us to our last question today, and that's for Dr. Henderson. And that is, can you rule in acute cystitis from a dipstick?
Yeah, so we often talk about ruling out things. So you're talking, this question refers to ruling in. Can we look at a dipstick and say for sure that the result, the positive result, if you will, a positive nitrite, a positive leukocyte esterase is absolute indication of cystitis? I love how Lisa has contextualized how she stated this. This informs and kind of tilts us a certain direction towards a diagnosis, but it's never a 100%. I'll tell you, in older patients, and it tends to be more often in older patients, we sometimes see patients that every time you check their urine, whether they have symptoms or not, that dipstick is positive. I would not regard that as acute cystitis without the symptoms present. So you whenever possible, need the symptoms in constellation with the laboratory results.
Great, thank you very much. Unfortunately, that is all we have time for today. So I'd just like to say thank you once again to Dr. Jeffrey Henderson and Lisa Ritnauer for today's informative discussion and presentation. And thank you to everyone for joining us online and for your interesting questions. If you do have any other questions, please feel free to email me at editor@selectscience.net, and I will follow up with your questions. To claim your PACE and accent credits and your certificate of attendance, please wait to be automatically redirected and help us evaluate this session. And if you would like to listen again to today's webinar, it will be available to watch on demand in a few days' time. So goodbye, and thank you once again for joining us.